Would you
Hello,
kindly
good
introduce
morning.
the case? So
Thank you, and hello NIC, hello Lucknow. My alma mater SGPGI is there. We are very proud to present this case for you today. With me is Dr. Shyam, Ramalakshmi, Andrews. So we'll start with presenting the case. Slide first. This is, next please. Yes?
Next slide.
This is a 66 diabetic, old infuvolumi, LV dysfunction, had a severe distal LMCA disease with CTO, LAD and LCX, and diffusely diseased RCA, which was an occluded vessel, had a bypass about 8.5, 9 years back with Lima to LAD, and 4 venous grafts, 1 to PDA, PLB, and 2 OMs, OM1 and last OM. He was last to follow up for the last 5 years. Next. Now he presents with ischemic LV failure, chest pain, TROP positive, non-ST elevation MI, anterolateral, because the new ST depressions have happened in V4, 5, 6. 1 AVL, NT-pro high. He took some time to stabilize. Still he is on BiPAP. His EF has dropped to 40 now with the new wall motion. There is hypokinesia in the anterolateral segments, no akinesia, viable territory, pulmonary edema. 3 days, still he is on BiPAP. In fact, we were thinking whether to intubate him now. His renal dysfunction is mild, EGFR 54, and the usual strategy for such cases, we do a CT angiogram over a catheter angiogram to get some idea about what is happening. We can discuss what is the strategy. Sometimes we do the routine angio as well. Here, the CT angio showed that the native vessels, CTO, RCA, LAD, LCX. Next. And the grafts, the Lima to LAD. Next, please.
Next
the
slide.
Lima to LAD is perfect, perfusing well. The last OM venous graft has
Next
multiple
slide,
mild segments of disease. The OM1 graft has got a critical subtotal occlusion in the proximal to mid segment with some diffuse degenerative changes as well, and a very small distal OM1. And the RCA grafts are occluded. That was anticipated at the time of surgery. It was told that the right side vessels were very poor in target. So here we have, next slide, an SVG to OM1 subtotal occlusion, culprit causing a recent non-STEMI, pulmonary edema, complex scenario, a chip PCI. So from the panel, yeah, what do you think? How should we go about?
Can I ask you a question? I mean, this patient is very likely to undergo an interventional procedure. So what is the advantage of doing upfront a CT scan when it's 100% that he has to go coronary angiography?
Yes.
So any comment?
Yes. So this is an interesting area of debate. Yeah. See, most of the times our protocol, if there are multiple grafts, say five grafts, we will have to hook them and give a lot of dye. Whereas with a single CT angiogram with one shot of 60 ml, we will get a preliminary idea about what is happening. We knew from clinicals and ECG echo scenarios that probably the SVG grafts either to first OM or the last OM is a culprit. Now we have got with 60 ml dye in a renal dysfunction patient with pulmonary edema. With minimal insults to hemodynamics and renals, we got the information needed. Now we can do the therapeutic procedure straight away with minimum dye. In fact, one of the strategies for today, even though it is a chip PCI, we want to use minimum dye and do it off probably within 40-50 ml.
Thank you.
You could, in some cases, do a straight angio if the grafts are not many in number.
Okay.
Yeah, that answers the question. And so what is the strategy? What does the panel think? How should we proceed? We have done, before we came live, we did a diagnostic. Shall we show the diagnostics and then we can discuss?
Yes,
show the diagnostics.
Absolutely.
Yeah. So show the first injection, left main, native, we just give 2 ml CTO. There is no chance of trying to do anything for the native LCX territory OM1. Next. The OM, the last OM graft, as was reported in CT, has got some mild diffuse disease, but no significant issues there. Next, our territory, next one, the culprit vessel graft, this is what is there. It is almost subtotal occlusion. Diffuse disease throughout, you have to know that it is a 9-year-old graft. Subtotal occlusion. And the nature of the graft, the flow, it looks like some calcification there as well. So these are the two views taken there. This was with a diagnostic catheter. We got an information from the CT angio that this was about a 2.6 mm graft. We know that the length of the disease was about 28-30 mm. We also know that where the graft is starting from, it is starting from 11 o'clock, just below the D4, D5 vertebra. So much information to hook it easily without any chances of unnecessarily scraping the aorta in these grossly atherosclerotic patients. So this is the issue now, very small territory. So we are not at, this was the diagnostic catheter, we are not yet engaged with the guide catheter.
So I have a couple.
So now we are just ready to go live, and yeah.
Yes, can I ask you a question?
Yeah.
So,
yeah, go ahead.
First of all, the approach. So do you prefer always the femoral approach in doing SVG intervention? Or, I mean, this can be an advantage of CT scan. You have the whole picture, you know what you have to treat, and you could also go by radial approach. Is it just your preference, or you think that for SVG intervention, the femoral approach is better?
I think we could do it with the left radial approach as well. We have done some cases from left radials. But here, we are in fact contemplating a supported PCI. What we thought is we'll do the PCI, and if needed, we can convert it into an IABP support as well. We've got the things set up for an IABP now. We don't want to do a preemptive IABP, but we want to use an IABP if needed, because he's still hemodynamically a bit unstable, frequent ectopics, he's on the BiPAP, an anesthetic standby for ventilation also is there. A classical chip PCI, that's the reason we chose the femoral route.
Yeah. Are you using any filters?
What does the panel think? Do you want to use a filter here? It is too tight, 99, and the filter itself would mandate a pre-dilatation here. What do you suggest? What do you think?
I think this case has a high risk of slow flow or no reflow. Okay, so something you can prevent with a filter,
yes,
but not, I mean, not, it's not everything the filter. So probably I would also be prepared with drugs in case you get a bad slow flow or no reflow phenomenon, like nitroprusiate and things like that.
Yes. Okay.
Have you taken a left
So
anterior
this is an issue here, because
did you take internal memory flow also, or
this way
you avoided because of this?
no, that was well seen on the CT angio.
Dye. Correct.
Yes. CT angio done. So the dye issues. So now what I was thinking was to go with the Judkins right, just go with a BMW, cross it, and we can obviously see a lot of calcium there at the lesion. So it's unlikely that my preferred strategy of direct stenting would work in this case, but still I would try and pass a stent appropriate length. I will measure with the BMW and try a delicate passing of the stent across and see. If the stent can track through, I would like to do a direct stenting, and then we'll use these strategies of deflation, inflation, which might reduce the chance of no flow, slow flow. Because we have done a lot of these venous grafts, I personally feel that many a time we can reduce the no flow, slow flow by this strategy of direct stenting and appropriate STEMI deflation strategies. So, but if the stent does not track, we will be forced to use a small mini dilatation and then go ahead with the stenting.
But
what do you
CT,
suggest?
but
Anyway,
your CT
GP2Bs we are
did
not going to
show
use.
Much calcification
Yeah.
on the OM grafts. Did the CT angio
Yes.
showed calcification?
Yes, in fact, they have reported more calcium on the, no, they showed the calcium in the other graft, venous
Yes,
graft.
so that's,
but honestly,
point.
even though the reporting was like that, I could see some calcium on this graft as well.
I
I
recommend
could
to
see the
use
calcium.
IVAS. So
Yeah, we can obviously it's calcium.
There is no
detect-
calcium on your CT scan in the SVG to OM graft. Either you believe your CT scan or you don't
Yes.
believe it.
Hello, can I make a comment here?
So, Reddy, I'm Dr. Hazran.
In fact, honestly, I was reviewing the films myself. I could see calcium in the graft,
Reddy, I'm
in the
Dr.
lesion.
Hazran.
I could see, and you can see it very well here.
The frozen shot.
Dr. Reddy,
Yeah.
we
Can
have
you
a
run
question
it?
from the
Even though the
audience.
reporting was no calcium on this graft. Yeah.
The extent of calcium
Yeah.
is not circumferential here. And on cine films,
Yes.
you are not seeing that great calcium. So I think simply going with the
Correct. Can you run the LAO?
extent would be doing the job here.
Reddy, you are doing a cheap case. You
Yes,
told me
I
though
think
it's
that would be the-
supplying a small area of myocardium.
Yes.
Look at the patient. He is having history of pulmonary edema.
Yes.
And he's got compromised either diastolic heart failure or systolic
Yes.
heart failure. Wouldn't you consider, you are prepared for the IBP, wouldn't you consider a pulmonary artery catheter? And if you have
Yes.
raised pulmonary artery pressure, you can give intrapulmonary nitroglycerin on the table, and you can avoid catastrophic edema on the table, and you can reduce the amount of dry if your PA pressure is going up. So you use IVAs, you use other models rather than depressing
Yes.
the ventricle with the dye. So I would suggest a PA catheter. If you are prepared for IBP, why not simple PA catheter?
Yes, I think that is a good suggestion, but here we want to keep it very simple here. The imaging part, you raised that appropriately. Here with this subtotal occlusion, unless pre-dilatation is done, we will not be able to do any imaging as well. So in fact, as was rightly suggested, I think a direct stenting possibility we will explore. If it doesn't work out, we'll do a mini pre-dilatation and then just go and stent it. And we'll show you the strategies which I personally believe would reduce the no-flow, slow flow. But I'm prepared for the no-flow, slow flow. The anesthetist is here, an IABP we can put in immediately. And we'll also show you the preventive pharmacology, what we use, even though, of course, there's not much of a proof in the literature about the preemptive pharmacology to reduce no-flow, slow flow. So if you're ready, we can start with the hooking the catheter.
Yes, go ahead.
Yeah. Small test.
So which wire are you using?
We are using the simple BMW. Small test? No, not too.
Above, sir.
Yeah, test. So that's it. Minimum dye. Small test. See, the flow will come down, we know it. Go down. We'll go to so now is the issue. We don't have much angiographic clues there. One option is to use a pre-dilatation and see, or go ahead and put in a 2.3 mm into 38 a stent and then see. There's no flow at all there. What do you think? Give a 338.
So it looks like it's occluded. We don't know if it's the wire or if it's already just low flow. But I
Yes.
have probably one very quick question. So why, what is the guiding catheter? Is an
Yeah.
RCA? So why did you use probably AL1 to have more support? Because there is some calcification and you may have issue in crossing the lesion.
Yes. I always use the JR for most of my left grafts, and I had no issues in my last charge experience. I use a AR catheter for the right-sided grafts, but for the left, I almost always get away with a JR. This is 2.3 into.
Are you using
3 into
6
38.
French or 7 French?
So what I'm planning is, this is a 6 French guide to reduce the dye.
So
We
for
are
this-
compromising
for
the
such
support,
kind
you are
of
right.
complex region,
But
I prefer to use 7 French.
Yeah. 7, yes, that makes better support. So what we're going to do is, we know the proximal landmark now. I'll try negotiating this very, very gently without risking any passage of the debris down. I can feed a lot of resistance there. So it is a calcific block. So it won't go. So we'll have to do a pre-dilatation, there's no doubt.
it's a long segment narrowing, so
Yeah, we'll not.
probably you would not be able
Correct.
to go with
So
the right backup that you are
it
having.
is a
it is not
calcific
giving a
subtotal
support to you.
occlusion, as I was thinking.
Sorry, which
Yeah,
slide
I don't
was
want to
that?
push the things there because this is a 338 Zines. We will use a 2 into 12, 212 NC balloon. So this is what I was anticipating. It's unlikely that with this subtotal
212.
with calcium there, it's unlikely it will hook in. Yeah.
Is the
215,
patient
okay.
having chest pain or?
No, he is sedated now. Saturations are okay.
Julio, the
Question,
question is to
90,
you,
yeah.
actually.
Get and go back.
In
So-
your experience and in your whatever you have done, all the research with stents, in vein graft lesions, can you specify why
Yeah.
DES versus self-expanding? We were looking at the self-expanding and now they have disappeared. And why not some of the other one is
Yes.
M-guard stent. So can you talk about that?
Yes.
M-guard.
I
We have
think
used
it's,
those before.
it's-
The M-guard, because
Yes, go
I
ahead.
think the evidence now as much is only for a drug-eluting stents. We are going with a balloon. The guide you can see, usually it won't give support, as you are right, small test. We can do a pre-dilatation there. We can see a clip-like thing there. I will use it as the
8,
10, 12,
10, 12.
deflate, fluorosave. So I don't want to do another 10. Much of dilatations there. Just a mini dilation and then deflate. Just to let the things go.
Dr. Reddy, what size balloon was that?
So anyway, all stents we are using are only this was a 2 into 15 NC balloon, fluorosave. So can you run that fluorosave? So we're done. We don't want to do any aggressive dilatations, just for the stent to pass. Now we'll take back the stent. He has been pre-baptized with ticagrelor aspirin. And of course, we're using unfractionated heparin here.
So just a provocative question. Would anybody in the panel consider, in this case, a delayed strategy, meaning that you delete the SVG, you do perhaps some 2B3 inhibitors, and you put the stent the day after, just to minimize the risk of an overflow? Because I'm really afraid that with this low flow, when you put the stent at high pressure, you're going to have a bad no reflow. Any
Yes.
comment?
Yeah. What is the? Any comment from the panel on that?
No data. It's a data-free zone.
Absolutely, it's a question of operator experience.
Yeah. So, yeah.
So if I'll intervene, I'll finish the procedure.
Small tests.
It's open.
Yeah. I know the guide support. This is usually we see this. So here, as we said, we just have to get the stent across. Small test. Small test. Yeah, I think we are happy with the things. And what we'll do is the inflation deflation strategy, what we use for venous grafts.
Can you describe exactly
So we are
what
going
you're
ahead to the nominal. Yeah, see, normally what we are doing for venous grafts is a modified STEMI inflation deflation strategy. We are going up to the nominal and then coming down to 6 or so, and again go back. So essentially, we are trying to minimize any microembolization and possibly sucking of the material by Venturi effect. So we are not doing any rapid deflations.
So, Dr.
So
Reddy,
very
in,
slow.
in 1 minute they will
We
be
call it
switching to the other live
thromboplastering.
case.
Yeah.
So if you're not finished, we will come back to you.
So I'm doing something called the thromboplastering. Yeah. So now we might anticipate a no flow. Let us see. So, nicorandil. Can you give me intracoronary nicorandil?
We have probably time to see an injection because we are all coolers, right?
Flow is not
Fluoro,
bad.
please.
Can we go back to the fluoro
Yeah.
images, please?
Fluoro, please.
Yeah. Can we?
Aaron.
No, dye. I need some dye. Yeah. So I'm injecting some nicorandil there into the graft. Yes. Yeah. So good. So what we have done is we have given that pharmacology. Can you show the pre-OCT run? The stent, yeah, this was the stent. You can see the screen. Stent pre-dilatation, stent deployment, 3 into 38 Zines. As I was telling, this so-called thromboplastering, no flow, slow flow reducing strategy was done for inflation deflation. And we found with small test shots, good result. Normally, we would end it with this one, take out the wire, one shot and come out. But we thought we'll see how things are with an imaging with an OCT. We used only about 30 ml of dye till now, so we said we'll use 20 ml for the graft and do the OCT. Can you show the OCT catheter? Next. And this was the final shot after the OCT. We'll show you the OCT run and we'll invite comments from the floor.
So
Can you show the OCT?
Did you use any drug after after putting the stent? Any drug?
Yeah,
in the
we
corner?
gave we gave nicorandil 2 mg, and after some 2 minutes we gave nitroglycerine 100, and then only we did the OCT run. And then of course the final one, you can see the final picture there. The territory is supplying some last OMs as well, and you can see the OCT run over there. The OCT is coming onto the floor.
This is what is being telecast there.
Yeah.
The stent looks well deployed.
You can see that the stent is good. There are no maloppositions. Usually we expect some amount of thrombus protrusion or tissue prolapses somewhere here and there. And it will be also interesting to notice how the venous graft, a 9-year-old graft, is behaving in the non-stented, so-called angiographically normal areas as well. We'll focus on that and then see, because we have some time now to discuss. We'll spend some time on that, and you can see that in areas where
Dr. Reddy, did you see any calcification on OCT?
Yes.
Did you?
After the stented segments, no calcium, no. In fact, can you show again? Can you show the run? We are not finding any calcium. Yeah, run it from there. Keep showing that. Now, distal to the stent, you entered the stent, struts look good. That was a small blood swirl there, well opposed stent. Here you can see between 9 to 12, there's some amount of tissue over there. Maybe some thrombus over there. You can see looking like a white thrombus, but well opposed. So no major tissue prolapses. Some amount of, again, some small areas of tissue prolapses or possible thrombi, which is very well expected in this scenario. This is one of the precise reasons why if we do aggressive pre-dilatations and post-dilatations, we'll end up with no flow, slow flow. Stent is well opposed. As we are coming towards the proximal edge of the stent, we left the proximal 1 centimeter of the graft untouched. We'll see what is happening over there as well. We didn't go to very high pressures. We went only to 14, and that too we did that thromboplastering deflations. You come over outside the stent, thick fibrous plaque everywhere. You can see some lipid core between 9 and 5 o'clock as well. No calcification at all. Thick, dense fibrous plaquing everywhere. The classical late graft failure scenario. But luckily, we don't find either in the normal proximal or distal segments, not much of tick fuzz. If we had seen much of tick fuzz, probably we should be covering it up in this index procedure itself. But we don't find much of thick, dense fibrous plaque without much of a necrotic core in the normal distal segment as well. This coincides and correlates very well with what our CT angiography people reported, that it is just only in that area, lower down it's very, very mildly diseased. Surprising, it's 9-year-old grafts, already 2 grafts are down, but still we didn't find much of the classical extensively degenerated scenario. So what are your thoughts on this?
Excuse me,
the OCT findings and...
Excuse me, sir, I'm a fellow. So I just wanted to ask, in this renal compromised patient, when you got a very good result angiographically, why did you go for OCT?
Dr. Reddy, did you hear the question?
Yes. Yes. As I said, normal protocols, we would not even venture out to do any imaging here because we know we anticipate certain scenarios. Therefore, for me, in this particular case, can you show the angiogram just after the stent? There was some problem of something seen there before the stent. We'll show you that. The previous one?
Andrew?
Before that, before the OCT run?
Before?
Yeah. Before that, yeah. There was some issue of possible, I was worried whether there was an edge dissection. The next one, the next.
Next one.
Or sometimes even the clot can longitudinally redistribute and accumulate over there. Next.
Andrew, next. Stent earthapdi.
Yes, yeah. Can you see that? Can you run that? Even though it is only a fluorosave small shot, run that. Before this.
Before one.
Yes. Can you see that before the stent?
Yes. Freeze it when the dye is there.
So you could see that there is some amount of negative shadow there just before the stent. This was, of course, before the preemptive pharmacology, immediately after the stent, little bit back. So that was the reason precisely we did that. And also, because the concern was in some of these cases, there could be angiographically not so visible, but extensive tick fast below, where there might be an essence in covering it up as well. But you are right, normal protocols, we don't do imaging unless we are stuck with a scenario where there is an angiographic doubt and we are wondering whether to put in one more stent. At this juncture, at the proximal to the stent, I was worried whether there was any edge dissection, which would have mandated one more, a 3.5 short stent to cover it up. But our OCT showed that it's quite good, clean, and absolutely no issues, just proximal to the stent.
I would probably add the comment for the fellow. So, I mean, there is accurate evidence, and now we have also 2 randomized trials, that if you use IVUS or imaging technique and you optimize the procedure, this is going to be translated in better outcome for patients. As I told you, there were registries that suggested that, but now there are 2 trials. One is IVUS XPR, the other one is a Chinese trial, and in both trials, the rates of events were lower using imaging.
So, sir, imaging should be used. Why not IVUS rather than OCT to look for dissection?
That's unsettled.
Because in this patient already there's renal dysfunction. So IVUS might have been a better choice than OCT.
May I take the opinion of the chair and panelists? You have seen the result. Now, how many of you would have used the filter in this case? Filters, distal protection device.
Now that I've seen the other vessel filling, I think the audience, what we all saw was what looked like a small distal territory, and maybe you might have thought, of not protecting with a filter because it didn't seem to be a big amount of territory. Only when there's good flow do you see there's a second vessel filling retrogradely, and actually it would have been a problem if there was a lot of distal embolization. So I think where the vessel is big enough, I personally would probably take a filter.
So I agree with that, and probably I would have used a catheter with a stronger support because I would have trouble in passing the filter there. But definitely I agree.
If I were an operator, I would like to do the pre-interventional OCT or IVUS imaging. Depending on the tissue characteristics of the intravascular imaging, I would like to choose or not to choose the filter. So pre-intervention imaging should be important.
So,
I think there was only one trial, as I remember, in 2008, where the filter was used versus the other group where direct stenting was attempted, and it didn't show much difference at all in no flow, slow flow. This was in 2008 from Japan, but again, this was a small number from a single center. I think Obawa's series, but in our series, I think we have done probably about 500 venous grafts in the last, my last filter usage was 3 years back, and with appropriate care of minimizing the pre-dilatations and avoiding too much of post-dilatations, we are getting a good result. Looking only by angiography, one would be tempted, if you are looking from a native coronary angioplasty point of view, to do a post-dilatation and get a bigger lumen. But here, this is the scenario where we should not do it, and you have the evidence there from the OCT that it's quite well opposed. And one more precaution is not to oversize the stent size or go for extremely high post-dilatations. And as you said, yes, distal protection, if you are using it well often and then if you are happy with it, you should use it. But in an extensively degenerated graft, I would use. Here there was another peculiar problem. The stent we thought was going to come to the mid-low part, and the distance from that to the native vessel should be at least 3 centimeters to be safe to play around with the filter wire. That is one concern here. And the deliverability of the filter without pre-dilatation is almost not possible here. You have to do a good pre-dilatation and then take it up. And then that 3 centimeters foot plate where to work on also is a little bit suspect here.
So how
but
long
yes,
you
you
are,
could do it, evidence is there. But I think if you see the international registries.
Dr. Reddy, how long you are going to use Brilliant?
Brilliant is, yeah, that's a very interesting question, because we checked this precise DAP score, it is 25. 25 and below is a low risk group, and it is a high risk scenario for thrombosis. I would like to give for 1 year, and if there is no bleeding issues at all, I might continue 60 BD for even up to 30 months as well. This is a classical scenario where you need to use a good DAPT. Fortunately for us, despite his mild renal dysfunction, the precise DAPT is only 25, and he doesn't have any bleeding issues till now.
Great. So I think since other lab we are not going back, we can conclude the session here.
Yeah. Okay. Thank you very much.
Total contrast was minimal use actually in this case. So like to thank all the chair and the panelists, and thank Dr. Reddy for the wonderful presentation.
Good job.
Great job, Dr. Reddy. Great job.
Perfect. No problem.
Thank you.